session, afternoon session. Welcome to Monaco and thanks for being here, although it's beautiful weather outside. But I think we're going to have some beautiful stuff to show you. I don't think I say too much if I say hyaluronic acid is one of the hot topics today in clinical dentistry, but also in scientific dentistry. If you look at the publications, if you look at the clinical cases we see, then this is one of the hot topics of oral regeneration. And that's why we're here this afternoon. We brought together for you a wide array of experts. We're going to guide you a little bit through the world of hyaluronic acid. We're going to start a little bit with the basics, and then we go over to GBR. How does hyaluronic acid help us in GBR technology? Then we go over to non-surgical therapy, non-surgical periodontal therapy. How good is hyaluronic acid in helping us to treat periodontitis in a non-surgical way? And we end with aspects of peri-implant disease, peri-implant mucositis, and peri-implantitis. It will be a quite nice session. You will have the chance to ask questions. We have the top-notch experts here, so I'm pretty happy to host for you the session. My name is Stefan Fickl, and I'm very happy to guide you through the program. Without further delay, I want to hand over the microphone to Mr. Periodontology, Tony Sculean. He's the head of the perio department of the University of Bern. Tony, you did a lot of these groundbreaking studies of hyaluronic acid, not only preclinically, also clinically, and you pretty much got us on this track of seeing hyaluronic acid as a method for oral regeneration. And we have you here to give us a little bit the scientific background of what we know today and what we maybe not know today. And with this, Tony, please, the word is yours. We're happy for your presentation.
So thank you very much, Stefan, for this introduction, and I'm very glad to be here in Monaco. And I would like to give you the biologic background to set the stage on this topic, because it's quite interesting and there's still many aspects we don't exactly know. But I would like to show you some of our data and put in perspective the clinical applications. So in fact, we are talking about a material that is not novel, because you see this substance has been first described almost 100 years ago, and the name originates from this part of the eye, the so-called vitreous humor, because they have isolated it from there. And if you look at the medical and biological literature, we have thousands of papers dealing with hyaluronic acid. But hyaluronic acid is not hyaluronic acid, because there are many different molecules, many different formulations, and our body also produces hyaluronic acid. An important feature is that our organs are embedded in hyaluronic acid, and the older we get, the less hyaluronic acid our body produces. And in fact, many biological processes are mediated through hyaluronic acid. One simple example is the scarless healing. For example, if you do a surgery at a fetus, then usually you don't see scar tissue afterwards. And the older we get, the more scar tissue we form. So in fact, another important feature of hyaluronic acid is its hydrophilicity. So it attracts the water, and usually one molecule of hyaluronic acid may bind roughly 30 molecules of water, and of course the blood is also consisting of water, so we have all growth factors indirectly in that area. What we know from the literature nowadays is in fact that when we have a wound in the body, doesn't matter where, we have a high concentration of hyaluronic acid during the healing process, and usually we have a peak after the 3rd or the 5th day, and it accumulates in the extracellular matrix. So at the beginning I was very careful when we started working on this topic, because I didn't know much, so we started with biologic studies in order to set the stage. And in fact, the preclinical testing that we first started with was an in vitro experiment in our laboratory for cell biology with Professor Asparuhova. And in fact, what we did is to look at the effects of two formulations of hyaluronic acid, one cross-linked, large molecular weight, or another formulation that was not cross-linked, on the features, migration, proliferation of soft tissue cells, primarily periodontal ligament cells and gingival fibroblasts. So first, we found out that the hyaluronic acid preparations didn't exert any negative effect on the viability of the cells. And when we look at the proliferation of the soft tissue cells when they get in contact with hyaluronic acid, especially the cross-link formulation, and I speak about the Regedent BG because that's a large molecular weight cross-link that has a so-called anti-inflammatory effect, you can clearly see that we have a significantly higher proliferation of soft tissue cells compared to the negative control. And when we look now at the migration of these cells over a plate that is coated with hyaluronic acid, you see the same features. Please look at these two bars, the red and the green one, and look at this cell nuclei. You can see that a plate that is coated with hyaluronic acid attracts significantly more cells, and these cells proliferate over these surfaces. And then what are these cells doing? These cells, in fact, are going to produce indirectly growth factors, primarily growth factors that are related to soft tissue healing. And here I talk about PDGF, platelet-derived growth factor. They produce FGF2, fibroblast growth factor, or IGF. And all these growth factors stimulate fast wound closure and also a certain degree of regeneration. And another important feature that we observed is in fact the anti-inflammatory effect. And this can be clearly defined by this marker EL1A, EL1B, or TNF-MRA. And in fact, we have several times repeated the experiments, and the results were always the same. So concluding, we know that the cross-linked hyaluronic acid is fully biocompatible, doesn't have any negative effect on the viability of soft tissue cells. It promotes migration and proliferation of the cells and expresses indicators of scarless wound healing. It's very, very important. And also upregulates the expressions of genes that encodes growth factors that are related to soft tissue wound healing and has also an anti-inflammatory effect. And then, of course, the next question is what do we do in a periodontal defect? And we have a very strong collaboration with our very good friend, my very good friend, Professor Shirakata from Japan, Kagoshima, very nice place, always hot. They have hot water there. So Dr. Shirakata performed a number of experiments together with us on the effect of hyaluronic acid in different types of defects. The first experiment was conducted in a standardized animal model, and we created this kind of box-shaped, non-contained intrabony defect. Non-contained means that this defect doesn't heal by itself perfectly, and these defects were treated with either hyaluronic acid using the Regedent BG. You see here this effect of the material because it stabilizes the blood clot. You can firmly see it also with the naked eye. Or we use the combination of the hyaluronic acid and the cross-linked collagen matrix. Clinically, the healing was uneventful in all defects, but when we looked now at the histologic evaluation, and we always start to the left, you see the overview picture, you see here the result following open flap debridement. That's the negative control. What can we see here? You see the root surface, and coronally to the notch in the root surface that indicates the most apical part of the defect, we have mainly a long junction epithelium and very little regeneration, limited to the area of the notch of cementum, periodontal ligament, and bone, and you see these features at a high magnification at this slide. However, it was surprising to us that when we use the hyaluronic acid, the Regedent BG, when observed in this case, you see this intrabony defect, we observe for the first time periodontal regeneration indicated by formation of cementum, periodontal ligament, and bone on this root surface, and the epithelial proliferation stopped at the most coronal part of the newly formed cementum. And at a high magnification, you see clearly these features. You have a very robust periodontal regeneration, indicating for the first time that we have the possibility to have periodontal regeneration when we use hyaluronic acid in a surgical setting. And of course, we can look at the histometric measurements, but this is not so important now because you know the conclusions. This was also statistically significant. Now, the second study dealt with the gingival defects, periodontal regeneration in recessions. Again, we performed a surgical approach creating this kind of recessions, and these recessions were infected via plaque. They were more or less comparable in their anatomical feature. One group was treated with a coronal advanced flap alone, serving as a control, or the use of hyaluronic acid, and you can see here the healing. Now when we look at the clinical measurements, one feature was very important, and this feature you can see here. At the baseline, where probing depth was more or less similar, no difference between the test and the control. However, at 10 weeks, we observed 0.6 millimeters less probing depth in the test group compared to the control one, which may indicate something. However, the real truth is always the histology, and if you look at these beautifully colored histologic images, you observe that in the coronal advanced flap group, the healing is predominantly characterized by a epithelial proliferation and limited regeneration of periodontal ligament and bone that was confined to the apical part of the defect. Now, when we look at one example in the test group, look at this beautiful regeneration of cementum, periodontal ligament, and bone coronally to the notch. And you see these features of cementum, periodontal ligament, and bone at a high magnification. And this study again revealed the possibility to regenerate the periodontium following the use of hyaluronic acid in a recession type defect. And when we look at the histometric measurements, there were robust differences between the test and the control group. Now, the third study dealt with a very challenging type of defect, namely class bifurcation. And the literature has clearly demonstrated, and we know it from the daily practice, that a complete regeneration in a class bifurcation is not clinical reality. So that's why we selected this defect, because I want to have a material that promotes the healing in challenging type defects. So class bifurcation were created, and again we use the same setting as in the intrabony component defect. We use hyaluronic acid, we use the negative control, and we use the carrier either with or without the hyaluronic acid. And then when we looked at the slides, and you see I like always to present every single defect, not only mean values. When we look at the open flap debridement group, we have some regeneration, but it was confined to the apical part of the defect. So it was a rather incomplete regeneration, and the regeneration was mainly characterized by an epithelial and connective tissue ingrowth, and of course some inflammatory reaction. Now when we look at the group treated with hyaluronic acid, we didn't observe a complete regeneration. However, if we measure the length of the newly formed cementum, periodontal ligament, and bone, it almost reached, in many of the slides, in many of the cases, the fornix of the furcation. It was not completely regenerated. However, the regeneration process seemed to be more robust compared to the control, and the same features were visible also in these slides where we combined hyaluronic acid with a cross-linked collagen matrix. And again, if you look at this table, we can clearly observe that when we used hyaluronic acid, you see the difference. Almost 8 millimeter of new cementum, almost 7 millimeter of new bone compared to significantly less amounts in the group treated with the carrier alone or in the group treated with open flap debridement alone. Now I would like to show you the last study that is quite important and sets the stage for a completely novel indication for this material. And the question was whether periodontal regeneration may be possible following non-surgical therapy. If you look at the literature, until now, this is not possible because we have many histological studies from animals and also human biopsies where all the healing resulted in a long junction epithelium and ingrowth of connective tissue. So no periodontal regeneration is, according to the literature, possible if you don't open a flap. And that's why we were keen to look at this particular aspect. And then we did a study, and this study was quite complex because first we created box-shaped like defects in an animal model, and these defects were infected with plaque. Okay, so we have used this kind of metal strips. They were glued to the surface of the tooth, and then the flap was closed. Why? In order to mimic a chronic infection. Okay, because periodontitis is chronic. And then, after a couple of weeks following this infection, we performed a non-surgical approach. In other words, we had two groups. One group was treated with scaling and root planing alone, okay, like we do it in the daily practice, using hand instruments, and of course removal of granulation tissue with curettes. And the other group was treated in the same way by using a so-called natrium hypochlorite formulation, the Peri-solve, to dissolve the soft tissue, and hyaluronic acid instilled in the pocket. And then we looked at the healing. We monitored the healing at 4 days, at 2 weeks, at 4 weeks, at 8 weeks. And we looked at the clinical parameters. And this is quite interesting. So when we look at the baseline, the probing depth between the control and test was no different. It's roughly 5.5 millimeters. However, at 6 weeks, you can see that the test group improved significantly more in terms of probing depth reduction, clinical attachment level gain, and reduction of inflammation indicated by less bleeding on probing. So we had roughly clinically a difference between the test and control of roughly 1 millimeter. This is very much, because in most studies that deal with local antibiotics, the difference is 0.2 millimeters. It's not 1 millimeter. And then when we look now at the histologic evaluation, histologic analysis, personally I was very surprised to see, in fact, a huge difference in terms of the quality of the newly formed tissues between the test and the control. Please have a look at this slide to the left. We have the root surface, we have the proliferation of the epithelial cells, and we have some regeneration in the apical part of the defect. We always have some spontaneous regeneration, always. However, when you compare the control with the test, you see a huge difference. You don't even need statistics here. You can see it also with the naked eye that we have less proliferation with the epithelium, significantly more formation of cementum, periodontal ligament, and bone in this area. And when we look now at the histometric measurements, that was really impressive. Please have a look here. New cementum, almost 2.5 millimeters. That's a lot if you measure it histometrically. In the test, compared to the control, it was 0.9 roughly in the control, and also 1.8 roughly bone formation in the test compared to 0.5 millimeter in the control. And another important aspect was also the length of the epithelium. The length of the epithelium was significantly less in the test compared to the control. And this is the first study in all the periodontal literature showing that we can obtain periodontal regeneration in a non-surgical way. That's why this study, I consider it very, very important because it shows also kind of change in our paradigm. Until now, it was not possible. So let me conclude, dear colleagues. The conclusion is very simple. These preclinical data strongly indicate that the use of cross-linked hyaluronic acid promotes periodontal wound healing and regeneration. And of course, it sets the basis for further clinical testing. And of course, the clinical application you will see later. But in fact, based on this study that I presented to you, we have the so-called clean-and-seal concept. That's quite simple. We clean a pocket using the natrium hypochlorite, sodium hypochlorite that softens the soft tissue and softens the calculus. We remove the granulation tissue, we remove the calculus, and then we instill the HYAD-NBG, the cross-linked hyaluronic acid, in the pocket and let it heal. And this has been beautifully demonstrated also by my colleague Dr. Ramanauskaite, who has performed pivotal clinical study on this, and she will present the data. So let me conclude with the fact that the use of the cross-linked hyaluronic acid in conjunction with non-surgical and surgical periodontal therapy improves periodontal wound healing and regeneration. And of course, you will see more data from my colleagues. If you are interested in this topic, I can recommend this recently published article in Periodontology 2000. As you know, is the best journal in dentistry. It is a very complex article summarizing the entire literature on this topic. So it is open access available. If you don't have it, you want to have it, you can write me an email and I will send it to you. You will find all the background and all the clinical studies. Is a beautiful summary on this topic. Thank you very much.
Tony, thank you very much for your presentation and congratulations to that groundbreaking work. I think we'll hear more from Egle about the non-surgical therapy of pockets with hyaluronic acid and also the sodium hypochlorite. Tony, before you leave, just one very quick question. How important do you think is the cross-linking? Is that one of the most important things, or don't see any big difference between non-cross-linking and cross-linking?
No, that's a pivotal difference. It's very important. It's critical because due to this cross-link formulation, the material stays in the wound. So of course, I didn't have the time to elaborate on this. But for example, when I'm doing my surgical procedures, for example, the tunneling approach, I know that I can increase the stability of the flap, the stability of the blood clot significantly more because the material stays there for a couple of weeks, maybe up to 4 to 6 weeks. And I place it also in the pocket before I close it or in the defect in order to keep it there. And in this way I can stimulate the cells, but I stabilize also the wound. Perfect. So it has also kind of a mechanic effect. Okay?
Thank you. And of course, Tony, I ask you the most pivotal question. This is for sure. Thank you very much for your presentation. We're going to have you afterwards for a round table. And with this, I would like to sort of introduce myself. And I would like to give you a little bit an overview of how we use hyaluronic acid for GBR procedures. And pretty much the beginning was pretty much the same. So we found that hyaluronic acid has an effect on wound healing. And I would like to tell you a story from science. You know how it sometimes is. Science sometimes ends meet, sometimes they don't meet. And some way back at the University of Würzburg, where I was, we started a study. And we found that hyaluronic acid, way before the time when Tony did these studies, we thought there is an effect. There is an effect on regeneration. There's an effect on wound healing. So we did a study where we did a GBR technique. We used the bovine bone material. We used the collagen membrane. And we had one group which we mixed with hyaluronic acid. And we did another one which we didn't mix with hyaluronic acid. And these were pretty much the cases. Just remember this 10 years ago. So there was no proof for hyaluronic acid. We just mixed up the DBBM material with hyaluronic acid. And we have these kind of critical defects. And what we did, as you pretty much see it here, classical GBR technique with deperiosteation or decorticalization here. And exactly that, what we did is we sort of mixed the DBBM material with hyaluronic acid. And in this situation, we also found that it's quite critical to use the cross-linked material. Classical technique, as Istvan showed us, it's pretty much the sausage technique which we used in that context. Used the collagen membrane and then pinned the membrane on the buccal side and then filled in the material in order to do the GBR procedure as you see it here, and then pretty much closed everything over it. Here you see the pinning process and the fixation. And now comes the interesting part. Look at this. We suddenly found that the biomaterial gets a different consistency. So it changed its consistency. As you see it here, coming in now. We didn't figure it really out when we did this video, but suddenly we see today, we learned from all of these scientific evidence we have that it changes its consistency, which helps us in a GBR procedure to make things more stable, to make a better container in that context. Now, coming back after 5 to 6 months, we saw these kind of results. We're quite happy with these results. Of course, installed our implant. At that time, as it was a study, we also did some trephines in the region where we placed the implants. And then, of course, finalized these cases. As you know it, implants successfully installed, soft tissue management, and then final restoration. And now, guys, I sent that to the histological lab 10 years ago. And I got an email, and I wondered about that email. They wrote me an email and said, Dr. Fickl, we got your specimen. Are you sure you removed the biopsy in the right area? Maybe you removed it here, maybe the calvaria, because there are no bovine particles in there. And you know what happened is sometimes you think, maybe they're right. Maybe I did something wrong. Maybe it came from the other side, yeah, or maybe I did something wrong. So this was the answer we get. There are no particles. There are no remnant particles from a DBBM material. You saw the augmentation. And this is the histology we got. And this is in German. They pretty much pinned that here. That, this is the only particle we found. And then they concluded and said, well, probably Fickl removed the trephine from a different area. And you know, when these things happen, what do? You forget about it, right? Because you don't want to acknowledge for yourself that it might be a mistake. So I forgot about it. Then suddenly hyaluronic acid came up, scientific evidence came up. We have Tony's studies from his lab, where he suddenly saw there's an effect on bone cells. So going back to our studies 7 years later, we found that that's from Tony's lab. We see, yes, there is an effect of hyaluronic acid on bone remodeling. So we see an activation of osteoprogenitor cells. We see a difference in renewal and differentiation of these cells. So suddenly we understood why there are a scarce amount of DBBM particles, what we actually never saw in literature. So we went back to the studies, and then we saw clinical studies coming up, of course also with different formulations, but they see pretty much the same. This is an experimental study, animal studies, on ridge preservation with DBBM material, either with or without hyaluronic acid. And they see the same. There's more mineralized bone in the group with hyaluronic acid, which we actually 10 years ago thought it was my mistake. So sometimes you understand things later, and I think today we understood that probably there's an effect of hyaluronic acid on bone remodeling and also bone mineralization. So of course we sort of went back to our labs and went back to our memories and got up that studies and published it. So published that 2 years ago, pretty much the first evidence, at least what I know, of a GBR procedure with hyaluronic acid and with a higher amount of mineralized bone. So we had different groups. We had DBBM material plus collagen membrane. You saw one of these videos. We had, of course, clinical measurements. We had histological measurements. And also we had patient-related outcome measures. From a clinical perspective, it was quite clear, very clear. Look at the data, very clear. There's significantly more bone volume in the GBR procedure combined with hyaluronic acid. But there's more bone. Although there's less residual particles, there's still more bone in these cases. And coming back to the histology, which is really, really interesting. And in the beginning, I really didn't understand it because I thought, this can't be true. I did a lot of biopsies in the sinus with DBBM materials, and I always saw a certain amount of residual particles, always. And suddenly we see when we use hyaluronic acid, there's less amount of residual particles, there's less amount of connective tissue, but it's an increased amount of newly formed or mineralized bone. So quite interesting. Of course, one study, I agree, we have to work on that even more, but we see there seems to be an effect of hyaluronic acid, not only in periodontal pockets, not only in surgical periodontal pockets, but also in GBR procedures. So pretty much this is our clinical regimen now. So we activate our DBBM material with hyaluronic acid. You see these kind of defects which we see. I would say some years ago, I would say this is a classical Curie technique. This is a shell technique. Today, I would clearly say you can do that with a GBR technique. We use osteosynthesis screws for containing the defect, for keeping the defect. Of course, we need to have that in a GBR environment. Otherwise, we get problems with the particles, with the movement of the particles. Remember, this is a real critical indication. And then what we do is we mix up the DBBM particles with hyaluronic acid. I also activate it always with some autologous chips. I still believe that autologous bone has an impact, in particular in bovine bone or in DBBM material, and we close everything up. So this is what we learned from these studies, is that we can activate our materials, and we see an effect on mineralization, but also renewal. Also, we see good healing. I think that has been alluded from Tony and will be alluded from the other speakers, that we see an increase of vascularization for our flaps in this clinical situation. And then when we come back in these cases, this is 5 to 6 months post, we see nice regeneration of these critical defect here. And if we open it up, we see these kind of situation following GBR. And this is quite unusual. Also, the picture when we use DBBM material, I've been working with DBBM material for over 20 years now. It always looked different. More granules, more residual particles, also for the naked eye. And of course, obviously, not a big deal to place 2 dental implants in this clinical situation and then finalize the case. Again, looking from the starting point, from the intersurgical view to the postoperative view. Very nice regeneration in a situation where 10 years ago, I wouldn't have dared to use a GBR technique. Now, if you analyze this case and finalize this case down the road, of course, there's more to it than bone. We also need soft tissue regeneration, soft tissue augmentation, good prosthetics, of course, but then we can successfully finalize these cases. So this was pretty much the starting point of this whole journey of GBR procedures. But then we also saw one point which I told you in the beginning is there is a different mechanical stability when we add hyaluronic acid to our bone grafts. So this accounts always for us as clinicians because it's quite important for us to have a good container for our GBR material. And probably this is what we see. We see a clotting of this material, of this DBBM material. And my colleague Frederick Kaufman did a series of in vitro studies. He compared what is the difference when closing the wound. So he did pick mandibles, he did GBR procedure and just closed the wound. And you know, a lot of the problem you created when you closed the wound of depression of the granules, of depression of the material. And there's a clear difference is when you're using hyaluronic acid to add to your bovine bone, when you not do it, you have a bigger mechanical stability as you see it here. You see a huge difference in the analysis we have here. So we have, when we use the materials, the bone grafts with hyaluronic acid and without, you see a way better volume stability, also visible here already in this micro CTs as you see it here, in particular in the critical area where you need the bone, in the most coronal aspect we see an improvement. So there's less depressing, less removing or less or mobilization of the graft material when we use this so-called sticky bone, meaning we sort of have a more mechanical stability of our granules. I would like to show you a pretty easy case, and I would like to get your view on one very specific aspect of that case. So I think it's a classical external sinus lift case. Of course, very, very straightforward technique we've been doing for many, many, many years. So classical external sinus lift, also here using DBBM material. But then comes the interesting point. You see, we're not only doing a sinus lift, but we also do a buccal build-up. So horizontal GBR in that case. And normally, what would you say? How successful are these kind of buccal GBRs following sinus lift? You do that a little bit for yourself, but let's be clear. I mean, you put bone granules on a situation where you have a lot of movement. You probably put bone granules also on the area where you did the window. So it should not be too successful. However, we followed this concept, GBR concept, hyaluronic acid mixed with DBBM material, mixed with autologous bone, meticulous wound closure, as you see it here. Nice healing, good healing. You see also a primary closure in that context, and also a good sinus elevation. And then the situation 5 to 6 months down the road. Pretty good as expected, nice sinus lift elevation, good situation for placement of my implant. But then if I look at my digital image, look at this. This is pre-op on the left. And for me, not important is the sinus. Sinus is quite clear. Look at this buccal aspect. Look at this. Very interesting and very unusual for an experienced clinician. It's quite clear that you will not get this amount of horizontal regeneration in these cases. Also from a clinical perspective, a very, very nice and beautiful regeneration. I didn't do anything. Was it just a GBR procedure of a membrane and DBBM material added with hyaluronic acid. Now, as you see it here, baseline and at situation of placement of dental implants, I think a really nice regeneration. And I'm pretty clear we have to follow that up also on a scientific aspect with the help of the clotting through hyaluronic acid. Of course, placement of the implant and finalizing the case. Now, any other advantage which we see? Well, there's one more advantage which I would like to share with you when it comes to GBR procedures. Of course, we saw the improvement of vascularization. Of course, we saw maybe an effect on bone cells. So we have better mineralization. We saw a mechanical effect with better stabilization of the wound. And what we also see, there seems to be an effect of hyaluronic acid on membranes. So we see that our membranes, our collagen membranes, they soak up the hyaluronic acid, and what happens is they absorb a lot of this hyaluronic acid, has been shown, and they also keep that. And by that we see a reduction of the collagen degradation, so we see a longer standing time of these membranes. And this is also a nice finding, a nice add-on for us as clinicians. So what we do is we soak these membranes with hyaluronic acid, and we have the evidence that it stays there and it helps us for the collagen degradation. We also have seen that in our study, going back to our study, we saw remnants. After 4 months or 4 or 5 month biopsies, trephines done, we saw remnants of native collagen membranes. Native collagen membranes should be gone after 4 weeks. We saw remnants of native collagen membranes in our histologies 5 months after surgery. So quite interesting that there seems to be also an effect. So this is also pretty much a case of how we proceed today. Classical GBR technique. You see a quite demanding situation, of course, a single tooth gap, so pretty much biologically pretty straightforward. However, also from the magnitude, quite big defect. So pretty much the same procedure, stabilization of this defect using of osteosynthesis screws. We sort of keep the container, and then we use DBBM material mixed up with hyaluronic acid, mixed up with some autologous chips. And a quite important thing is deposition of hyaluronic acid on the membrane in order to increase the standing time of these membranes. Of course, I mean, the biologic principles, they don't change. They don't change at all. I mean, soft tissue management is critical in these cases. You need a lot of flap advancement in these cases. You need a good stabilization of these flaps. But of course, this can help. Now, situation 5 to 6 months down the road, good soft tissue healing, good idea of defect fill, as I would say. And if I re-entry that case, it looks like this. And I would say pretty good regeneration for this really critical defect, which we see here. And of course, quite easy to place a dental implant in that context. And again, from where we started, baseline and situation 5 to 6 months down the road. And again, look at the different situation of which we see here after a GBR procedure with Merle bovine bone in that context. As a last case, also where I see a huge advantage when adding hyaluronic acid to our cases is our semi-open healings. I mean, I'm a big fan of socket and ridge preservation, and we always have the problem, it's a semi-open healing. We always have a dehiscence, we have an open healing of a membrane. And when we see hyaluronic acid is sort of slowing down collagen degradation, this might definitely help. So a clinical situation here, a lateral implant, of course, with a huge bone defect, of course, also with a huge infection around it. Peter, maybe it would be interesting if you would be able to treat it. I couldn't treat it at that time, so I decided to remove it and start over again. But you all know how challenging, how demanding these situations can be. So I took out the implant, I flapped this situation. You already see at the time of opening what kind of huge defect these peri-implantitis creates. And you already have to go through your mind. I mean, how do you recreate bone in this context to again redo an implant? Now I removed the implant, saw a huge bone defect, and as you see it here, huge bone defect, and again went with the same technique, GBR technique, addition of hyaluronic acid to my DBBM material, addition of hyaluronic acid to my membrane, also additional stabilization of this membrane with an osteosynthesis screw in order to get a better stabilization of the membrane. Here's the application of the membrane, application of the DBBM material, topical application of hyaluronic acid onto the wound, onto the flap, but also directly onto the membrane in order to get a longer standing time. And I would always call this a semi-open healing. This is definitely not a closed healing because we still have an opening where the old implant was. Healing, quite nice. This is also what helps us with these materials, is that we see nice vascularization in these kind of demanding defects. And when we come back 5 to 6 months down the road, The clinical situation looks like this. I would say acceptable regeneration for these huge defects which we created here. And when we open this clinical situation, again, look at the outline of the bone. This looks different to what I saw over the years. Yeah? Less granules already visible in a clinical setting. Of course, placement of a dental implant, completely in the bone housing, as you see it here, and then of course finalization of this case here with a closed flap environment or a closed procedure, and then nice situation of the healing. Also good healing here, same approach which I used in this context. I also add hyaluronic acid when placing my implants in order to improve soft tissue healing. This is already the finalization of this case after some soft tissue management and some prosthetic emergence profile contouring. With this, dear colleagues, I would like to close my lecture. I wanted to give you some insights more from a clinical perspective is what we see on GBR procedures. I think we have a lot of evidence, and we will hear some more evidence and some more clinical aspects in periodontitis, but also peri-implantitis. We have a scarce amount of literature in the field of GBR. We have to work on that, but we definitely see that cross-linked hyaluronic acid improves bone mineralization. We definitely see that. We have more vital bone. We have less remnant particles. We also see that the graft stabilization helps us. Mechanical clotting helps us definitely. And we also see that hyaluronic acid slows down collagen degradation of membranes, and by this gives you a longer standing time of membranes. Thank you very much for your attention. With this, I think we can discuss the lectures later in our roundtable. With this, I would like to introduce the next speaker. It's Dr. Egle Ramanauskaite from Lithuania. Egle, you were already introduced by Tony. I think you did, I would also say, a lot of these groundbreaking studies. To be honest, in the beginning, I also thought, non-surgical therapy, hyaluronic acid, does that really work? But it is just overwhelming what you showed in a clinical setting, but also in a preclinical setting. And we're very eager to hear your data, to see your work, and please, the stage is yours. Egle, please, we're looking forward to your presentation.
Thank you very much for a kind introduction. Dear Stefan, it's really truly an honor to share the stage today with so well-renowned colleagues. So today my task is to discuss this novel therapy, the therapy of CLEAN&SEAL in periodontitis in acute and persistent periodontal pockets. Dear colleagues, I am a periodontist, so I have to be sure you are aware that periodontitis is a chronic inflammatory disease that is associated with microbial dysbiosis. And if untreated, it leads to the destruction of the connective tissue and attachment loss, and ultimately premature teeth loss. We have to talk about it, and this is a major problem worldwide. Why? Because periodontitis is the main cause of teeth loss in adult population, and it is the 6th most commonest diseases worldwide. Various epidemiologic data demonstrates quite consistent results that in Europe, 2 out of 5 adults are affected by some form of a disease. So we have to be well aware of the periodontal statuses of our patients who are coming to our practices, maybe not necessarily seeking for periodontal treatment. Why? Because we might end up with situations like this. This patient got his prosthetic reconstruction a few years ago, and he was referred by the surgeon asking if I can do something about these implants. So very obvious that the perio status was not evaluated well before starting with any other procedures in a patient's mouth, and this is not an execution, this is just a simple probing, bleeding on probing, okay? So obvious the periostatus of a patient was ignored before starting with prosthetics and implant therapy. So whenever we do have a periodontal patient, we have to define what do we seek and what do we aim for. So according to the World Workshop in Periodontology, the ultimate treatment goals in treating periodontitis is the probing depth that is 4 millimeters and less and does not bleed on probing, minimal bleeding on probing that is expressed by less than 10%, and ultimate improvements in other clinical parameters and lack of periodontal destruction. And whenever we do talk about the treatment of periodontitis, we have to know that it's a step-by-step approach, where first we have to discuss several aspects with our patients, such as how their changes in their behavior and control of risk factors might attribute to the success of periodontal treatment. We also do perform a thorough supragingival plaque removal in this stage. Then, step 2, it's a cost-related therapy. It aims to reduce or eliminate subgingivally residing plaque and calculus. In other words, it's a subgingival instrumentation. Then we re-evaluate the patient after a certain amount of time, usually 3 months, and if we still do not achieve the treatment goals that we discussed before, we have to make a decision. What do we do? Do we re-instrument the site or do we go for surgery? So in this slide, thinking logically, we have to be as effective as we can in step 2 in order to reduce the number of surgeries in our clinical practices. And whenever we do achieve the treatment goals, we put the patient onto the maintenance, which aims to maintain the stability of periodontal tissues. So dear colleagues, now let's dive deeper in the cause-related therapy, subgingival instrumentation. So we all know, it's very classic, there's nothing new, that the gold standard is a thorough removal of subgingivally residing plaque and calculus, and it is well established by classic studies that subgingival instrumentation with ultrasonics, curettes, or the combination of both is an effective treatment method for periodontal patients in reducing pocket probing depths and gaining clinical attachment. However, here we face some clinical challenges. It's not so easy because there is data that shows us that even a very thorough subgingival debridement, the total surface area of the debrided roots may still be covered in residual plaque and calculus. And this results in a very fast recolonization of already treated sites, and clinically we do observe persistent pockets which do require further attention and treatment. And as I mentioned before, as periodontitis is infectious in nature, there is some logic to use some adjunctive materials, agents, to eliminate or inactivate periopathogenic species where mechanical instrumentation is invidious. So in this slide, dear colleagues, I would like to present the CLEAN&SEAL technique. So what is a CLEAN&SEAL technique? It consists of 2 constituents. The first one is a sodium hypochlorite amino acid gel that is known as Perisol, and another is a cross-linked hyaluronic acid of high molecular weight, is known as Hyaluronic BG. What is the step-by-step approach of a method? So theoretically, I will soon demonstrate it clinically. If we do have a pocket which we aim to instrument, we prepare the sodium hypochlorite amino acid gel, instill it to the pocket approximately 1 minute prior to instrumentation, and then we start subgingival instrumentation. We perform the subgingival instrumentation with ultrasonics, hand instruments, the combination of both, whatever works best in our hands, always having minimally invasive methods and techniques in our minds, and we may reapply the material several times until the root surfaces are smooth upon probing with the Explorer probe. And whenever we do think that we are efficient, we apply a cross-linked hyaluronic acid to the treated site. How does it look clinically? So here we have some deep pockets, specifically on premolars. And we know how sometimes tricky the anatomy of the roots might be and quite difficult to clean. Here we prepare sodium hypochlorite amino acid gel that is known as chloramines. It means when chlorine meets amino functions from the amino acid, and we apply it to the pockets prior to instrumentation. The material, as Tony told, has the pH of 12, so it's quite a high pH, which has a softening effect on calculus and makes the instrumentation easier to perform. We then perform the subgingival instrumentation, always very fine, thin, ultrasonic tips, mini curettes. As I mentioned before, we may reapply chloramines to the pockets several times until we feel we need to do so. And here we take, when we do think that we are efficient, we take the cross-linked hyaluronic acid. The cross-linking technology leads to the fact that the material is very viscous, okay? So we apply it to the pocket and it may remain stable for in the time frame from 4 to 6 weeks. And here we apply the material to the pockets after the instrumentation. We see the ability of hyaluronic acid in making the blood clot very stable. And this is an important prerequisite for a primary healing. So, dear Tony explained much about hyaluronic acid, but I have to mention the Perisolve, that is the chloramine gel, because this is an important factor in this duo. So several basic studies. The first study is an in vitro study by the Bernese group who evaluated the antibacterial effect of Perisolve, of chloramines, and they found out that this gel acts antimicrobial against gram-negative species that are associated with periodontitis. Another important observation was observed that the component of sodium hypochlorite is able to alter the matrices of a biofilm, and later I will explain why is it so important. What about the histological evidence? And here the group from Romania treated experimentally induced gingivitis, periodontitis, in many different techniques, and they observed that the best histologic healing in terms of tissue and cellular repair was observed in the group where scaling and root planning was combined with Perisolve. So this material has something to do with the wound healing. How do we translate it to the clinics, to everyday practice? So here, my friend Vincenzo Siciliano and the Italian group performed a clinical study where they added Perisolve in minimally invasive treating periodontitis, and after 6 months of observations, they made a conclusion that the adjunctive application of this material led to significantly improved probing depth and gain in clinical attachment compared to conventional subgingival debridement. So actually they made a conclusion that this is a valuable adjunctive approach. Another very recent study where residual periodontal pockets were treated and observed for 1 year. After 12 months of observation, they observed significantly reduced bleeding on probing in Perisolve's group compared to chlorhexidine or placebo. And from a very classic studies, we know that the absence of bleeding on probing is a reliable predictor of the maintenance of periodontal health. So this is important. I often get asked, how does sodium hypochlorite, how is it compatible with the soft tissues? And here is an interesting study which is totally non-dentally related. Here the chloramines were used for the treatment of diabetic ulcers, and it was observed that the repeated treatment of the ulcers with chloramines resulted in significantly improved wound healing. So this is an important observation. How do we translate it clinically? Here we applied the Peri-solve to the deep periodontal pocket, and we see the degranulating effect of the material. The granulation tissue is coming out easily without any adjunctive effort. How do we translate, how do we connect all this knowledge and translate it clinically? So here we performed a clinical case series where we treated 21 patients with clean and seal approach. We observed the patients for 6 months, and of course we saw significant improvements after 3 and 6 months compared to baseline. However, very interesting observation was made that between the time frame between 3 and 6 months, we still had significant improvements in all investigated clinical parameters. It means the probing depth, clinical attachment level, and bleeding on probing were still getting better.
Sorry, Egle.
Yeah?
You change the microphone. We have an issue with your headset.
Oh, really? Okay. So all of the investigated clinical parameters were significantly getting better, even no treatment procedures were performed in this time frame. So we made a conclusion that this might be a valuable treatment approach in treating periodontitis. A clinical case. A never treated periodontitis young male patient, deep pockets, bone loss. The protocol is always the same. We prepare chloramines, apply it to the pockets, cross-linked hyaluronic acid, and after 3 months I have 4 millimeters with a minimal soft tissue recession, which we could expect after this massive pocket. 6 months we have 3 millimeters. It's still improved a little bit, and the formation of a new bone. And after 12 months, we still see the stable 3 millimeters probing depth with the formation of a new bone compared to baseline. What if we compare this treatment to the standard treatment, subgingival instrumentation? So here is a randomized controlled clinical trial where we had 2 groups: control group, standard subgingival instrumentation, and test group, clean and seal. So for the final analysis, we distributed the pockets into moderate and deep, and again, the same patterns were observed. That is, we had significant differences between test and control groups in terms for the test group, and again, significant improvement in the clean and seal group. It means that the probing depth reduction was still improving, whereas it was not in the control group. The same was in all investigated clinical scenarios. Clinical probing depth in deep pockets, that is 7 millimeters or more, and significant improvement in clean and seal group between 3 and 6 months follow-ups. Clinical attachment level, moderate pockets, significant improvements in favor for the clean and seal group in moderate deep pockets, as well as in bleeding on probing. A very recent analysis, which is not published yet, but I'm sharing it with you today, is the analysis of the pocket closure rate. It means that the pockets are not active anymore. It's 4 millimeters and it's not bleeding on probing. So if we have the initial pocket probing depth of 5 to 6 millimeters, we have pretty similar results. However, it gets more interesting with a more deeper initial probing depth. For instance, if the initial probing depth is 8 millimeters or more, only 40% of these pockets are closed after subgingival instrumentation, and 91% of these pockets are closed in the clean and seal group. Isn't it great? So we made a conclusion that clean and seal not only significantly led to higher clinical improvements, but actually is a valuable treatment approach in the step 2 of periodontitis treatment. Another clinical case, this is just a small piece of very complex case, orthodontic perio patient. So we have an extremely deep pocket that is associated with an intrabony defect. We continue, repeat the protocol, the preparation of chloramines, insertion of chloramine gel prior to instrumentation, then subgingival instrumentation, and the application of cross-linked hyaluronic acid to the treated site. After 3 months, we see a probing depth of only 4 millimeters. So basically we achieved our treatment goal because it's not bleeding on probing, and radiographically we see the formation of new bone. After 6 months, again, it's still stable, it's 3 millimeters, and we can observe the formation of a new bone radiographically. Actually, I saw the patient recently. She's undergoing the orthodontic treatment now, and still the probing depth is stable, 4 millimeters or less. Dear colleagues, at the beginning we discussed that periodontitis is of microbial origin, okay? So what if we checked the effectiveness of this method on periopathogenic species? And again, a randomized controlled clinical trial, 2 groups, subgingival instrumentation and CLEAN&SEAL. And the first analysis is the detection frequency sorted by pathogens, 5 basic pathogens. It means either it's detected or not. So after 6 months of observation, we saw significant improvements in favor of the CLEAN&SEAL group for Porphyromonas gingivalis, Treponema denticola, and Prevotella intermedia. And from the literature, I know that if I get rid of this bacteria, it's a success of my periodontal treatment. Again, the total bacterial change, counts change after 6 months, significant improvement for AA, Aggregatibacter actinomycetam comitans. And I think that it's an important finding because we know that this bacteria is able of invading the epithelial cells and surviving inside the epithelial cells, and sometimes is resistant even to high doses of systemic antibiotics. So now we see that there is some rationale of the Perisolve being able to alter the matrices of the biofilms. Significant improvements in other investigated bacteria that are in favor for the CLEAN&SEAL group, that is Ternarella forsythia, Porphyromonas gingivalis, Treponema denticola, and Prevotella intermedia. And we made a conclusion that actually the microbiological outcomes supported the observed clinical improvements that were seen. Another clinical situation, deep periodontal pockets, furcation involvement, preparation of chloramines, insertion of them to the perio pockets. Now you will remember the protocol really good because we are repeating it a lot. Instrumentation and cross-linked hyaluronic acid. After 3 months, I have 3 millimeters. The patient actually is a heavy smoker, so we have some impaired healing processes, and he disappeared for some time. Now he visited me recently, and I still see that he is exhibiting 4 millimeters of probing depth, so it's not so bad. And after 3 months, 4 millimeters and no bleeding on probing and a closed furcation. I cannot probe a furcation anymore. After 12 months, it's still stable. Dear colleagues, so this was step 2. Do we have any evidence in other steps of periodontal treatment? So here very shortly, I will present the results of my colleague, Professor Anton Friedman and his group. So they checked the effectiveness of this technique in step 4 in maintaining in non-healing periodontal pockets. And again, they had 2 groups, conventional instrumentation and the CLEAN&SEAL. They followed the patients for 9 months, and they found out that after 9 months, the probing depth reduction, clinical attachment level, and gingival recessions were significantly better in favor for the CLEAN&SEAL group. And again, they observed the same pattern
the continuous improvements in clinical parameters between the time points, even though no treatment was performed. The pocket closure rate, again, very consistent with our results in deep pockets, twice as big as compared to subgingival instrumentation. So actually, this approach not only led to significantly improved clinical parameters, but also showed some regenerative response to the treatment. One last case, deep pockets, we see pus, so we expect a lot of anaerobic species, subgingivally, perisolve, hyaluronic acid. 3 months, we have 4 millimeters with, to my mind, minimal recession. For this case, 6 months, 3 millimeters, it's stable. And I saw the patient again recently. At 12 months, it's 3 millimeters with no surgery. With this, dear colleagues, I would like to thank you for your attention, and do not forget to visit the booth of Regedent.
Yeah, dear Egle, thank you very much for this nice presentation, and also thank you for your work. Maybe just one quick clinical question. How important is it to use the sodium chloride? I mean, could I also use maybe EDTA or chlorhexidine? Is it really important to use this?
I think so. We made investigations on these techniques, as I do believe in minimally invasive non-surgical principles, so we never aim to irrigate subgingivally with chlorhexidine, which is not compatible with primary wound healing. Okay. So I think that it's important feature that it can degranulate the infected tissues. I think it's important.
Thank you. We'll have you back on the round table. Now, it's maybe the highlight at the end. Peter, some people say periodontitis is easy, but peri-implantitis is the deal. And we have you here. We have Professor Peter Windisch, who is the chair of the perio department in Hungary. Peter, we want to hear from you. Do you have a solution for peri-implantitis, yes or no? And we very much
immediately or after the lecture?
Immediately. We're looking forward
no,
to your.
Then they will go.
Yeah, they will go. We're looking forward to your lecture, and we're happy to have you also for the discussion after.
Stefan, thanks a lot. Thanks for the kind introduction. Peri-implant infections. Yes, my colleagues, dear friends, I have peri-implant complications. Many of those colleagues who are presenting, they have only nice cases. I have complications. I'm pretty old enough to present also sorrow cases. So therefore, I like to start with my lecture with a case. But before presenting the case, an interdisciplinary approach will be presented by a stepwise way using the CLEAN&SEAL concept, followed by prosthetic, soft, hard tissue interventions. So this is the real chronologic order of the radiographies, and this is very important to get mentioned, because normally it looks like 1, 3, and 2. To achieve a healing after the second radiography, resulting in a third one, I think that is really the take-home message. So if you'd like to hear what I offer for acute, absolutely acute, swollen cases, which was placed by myself. The first implant was placed and the second implant, due to the lack of enough hard tissue, was placed later. So the bone was augmented and the tissue level implant was placed, and around the tissue level implant an acute infection occurred, and using the CLEAN&SEAL protocol that happened, and that is the final result when I could insert also when I could also do the prosthetic loading. So starting with the healthy is not so important to mention. This is also based on the same consensus statement Egle presented before very nicely, and I would be somewhere in between Stefan and Egle. So the closed healing, what was propagated by Egle, is absolutely the first requirement for any implant healing, But if it's not, then we should go for some surgical approaches or interventions. A peri-implant has no signs of bleeding, no signs of suppuration, absolutely painless and complication-free conditions for the patient, and even can exist with reduced bone support. The second question is, for how long time? The second part is,
Sorry, Peter, we have also an issue with the
yeah. The second case is the so-called early inflammatory process, where the inflammation is confined to the oral mucosa. The main sign is the elevated bleeding, the bleeding on probing, and probably elevated probing depth. And the very thorough issue is when we are facing to a progressive supporting bone loss, and also the bone involvement is quite clear. Here, the clinical features are either bleeding on probing or absolutely absence of bleeding on probing, but suppuration. And due to the fact that this is an ongoing process, sooner or later, this category could lead to a explantation procedure, where we can see that the last category will be mentioned, that we can have peri-implant hard tissue deficiencies and soft tissue deficiencies and peri-implantitis, and these deficient conditions are the bad guys working together with big guns. And as Stefan presented the case, it's not so easy to get a proper solution for that. So, and these are not implants. The bridge is holding the implants in situ. So therefore, if we remove these implants, then it's quite obvious that we are lack of hard and soft tissue at the alveolar ridge. So these deficient conditions and peri-implantitis conditions should be absolutely in the focus of interest when we start with the early beginning process and the treatment options for that. Then the first line is always, as Egle presented, the professional mechanical professional mechanical biofilm removal and an improved patient plaque control. Whether we have some adjuncts which could help, we have limited evidence to have additional benefit. The peri-implantitis therapy should focus on also a mechanical debridement, first non-surgically. This is the second question, whether the surface of the implant should be somehow decontaminated or can be decontaminated. Then probably, which also could be mentioned at the mucositis part, the prosthetic revision of the work. Then some surgeries are needed, but these surgeries are always individualized and should be much more dependent upon the defect morphology and the patient compliance. Some early studies before using the CLEAN&SEAL concept, that was the Peri-solve additional evaluation. One of our friends, Vincenzo, presented this data, and this gives a very good can help us to get a better healing, but not significantly. And the Peri-solve is very effective to clean the inflamed tissues, but the longevity of this is not given after 6 months. So therefore, for 6 months healing time, this is not enough. So therefore, probably, if we want to stabilize the wound, if we want to have a longevity of the antiseptic therapy and some helping agent inside the defect, then the hyaluronic acid could be very, very useful. We start our therapy with the mechanical debridement and the CLEAN&SEAL concept. This is a part of our study, which will be also shortly introduced. You can see the same concept. First, we have a proper diagnosis that the bleeding is given and the probing depth is a little bit deep. Then we chemically treat the inflamed tissues and dissolve them from the healthy tissues. Then mechanical submarginal instrumentation, and then the usage of the hyaluronic acid stepwise. I don't want to go into the details because it was presented before several times. So some of our data, you can see that 40 implants were randomly treated either in the test group where mechanical cleaning and plus CLEAN&SEAL was applied. In the control group, only the mechanical debridement was performed, and only single unit crowns were treated by this concept. And you can see that all in both groups, statistically significant improvement was detected, but the real differences where statistically significant difference was found was at the deeper sites where the initial probing depth was deeper or at least 5 millimeters. So that means that from 5 millimeters, as Egle presented also several times, without having gingival recession, you have an improved healing inside. Here is a very similar factor, but you can see that without having recessions inside the defect, ongoing healing started. Once again, the early detected acute inflammatory process during implant abutment connection, the site was infected, slightly painful for the patient, and also bleeding occurred when we removed the healing abutment, and during that we realized that the infection and the bleeding is huge. So therefore, starting with this deeper than 5 millimeter measured probing depths, the bleeding, and then, so sometimes it doesn't work. Now it's working. Also, you can see that we found acute demineralization in the supported bone, and the cleaning and seal, CLEAN&SEAL concept with the mechanical debridement and completely eliminating the dissolved granulation tissue around the implant, and then to close to have a closed healing inside the wound, we selected only one time placed abutment, screw retained abutment with a screw retained crown, and on the top of the abutment you can see that due to the not high lip line, it can be absolutely accepted that the crown margin can be visualized, not the crown margin, sorry, the titanium abutment can be visible, but for a patient perspective, I think it's better not to furtherly manipulate the tissues. A final good hard tissue could be regained. So if we detect early these cases and acute conditions can be found, then it's very likely that we can be much more effective. And I want to emphasize the importance of the so-called closed curettage. And the prosthetic revision could be the next step. So when we go a little farther and further, we can say that not only peri-implant mucositis will be treated, but also cases like in the first slide, you can see that we have the non-developed, previously mentioned biological widths around an implant. So the supracrestal vertical mucosa dimension is not given because the abutment is too deeply located. Then we have the so-called moderate peri-implantitis, where we have between 1/3 and 2/3 the bone is involved. And then we have the advanced cases, and I strongly recommend that for these cases, the best therapy is the explantation to remove the implant. So we treated all these sites where, let's say, not the 2/3 and below located bone configurations with the CLEAN&SEAL concept, and we wanted to see how long the result can be maintained and how can we even improve the situation. Before starting my cases, one study about the same. These are not published data yet. Anton Friedman will present this data. This is the CLEAN&SEAL concept for treating peri-implantitis. 30 patients were enrolled in the study, and during the first treatment, before the treatment was performed, the site was evaluated whether they have 5 millimeter or deeper pocket plus bleeding on probing, and after 6 months it was re-evaluated before doing the same therapy, and some 12 months later, the final evaluation of these patients were performed, we can see that a very dramatic improvement can be demonstrated, more than 4 millimeter pocket reduction, but after that, a slightly getting worsening condition of these sites, so a kind of relapse also, that the first 6 months presents a very good healing, but after first 6 months, some additional, it's true, bless you, some additional intervention is needed. And this is also for the bleeding on probing. So therefore, we think that the prosthetic revision could be also very useful. So if you have an early detected case with a marginal bone loss, then probably the prosthetic revision can help. You can see that we want to have an absolutely low profile individually formed prosthetic work, and below the submarginal level only absolutely either titanium or zirconia material can be located. If we can have the opportunity to select the abutment properly, then use abutment which is suitable for screw retained crown work, and you can see that these only once positioned abutment can be very, very useful to maintain the tissues. This is very similar, so when we clean the defect, we want to have only the proper abutment placed, and further manipulation will be only performed above the abutment. So our goal is to reduce and biofilm inflammation below the gum level, screw retained abutment level restoration, polished convex emergence profile, no bulky contours, and a kind of prosthetic that supports the inner healing of the tissues, and the cleansability should be given. So only one, I think, very nice and really highly polished prosthetic work of our private office, where we realized that the previously on the first picture, you can see some deposits, some not highly polished prosthetic remnants of the porcelain. And when we polished it highly, and in between we also gave a little bit of concave contour of the prosthetic work, it could help not only to stabilize the tissue and maintain the tissue absolutely healthy without having any inflammatory process in there, but also to give improved connective tissue ingrowth. And as you can see here, before the CLEAN&SEAL concept, the bleeding was quite obvious, and after using the CLEAN&SEAL and replacing the prosthetic work, and the difference is, I think, also can be immediately read on the radiographies, a diffuse radiographic lesion on the left side, on the left side, and the corticalization on the other side. So if we can achieve a corticalized configuration at the marginal bone level, I think that is a very good feedback that the longevity of the therapy will be given. So we found this kind of approach quite promising, and even the aesthetic outcome could be maintained, what previously existed on this patient, where we should have a very long mucosal support to have an aesthetic solution. So we wanted to have a retrospective evaluation on those implanted sites where we have some peri-implant like bone loss or hard and soft tissue deficiency combined with bleeding. And we wanted to also have some radiographic bone level measurements. This is a typical case. The patient is a peri-implantitis patient. Therefore, without follow-up, there is a high susceptibility that the patient will have peri-implantitis on the same sites. We treated in this protocol mostly periodontally susceptible patients, and as you can see, mostly stage 3, 4, and stage 2 were treated. And the severity of the peri-implant bone loss, we tried to focus on not too advanced peri-implant bone loss cases. This is not to focus on very advanced bone loss cases. You will see how it was solved. That is the solution, to focus on not so advanced cases. So one implant was retrieved, and the other two implants in the posterior mandible were treated with the peri-solve concept. And these are the baseline bleeding on probing change, and 6 months after, dramatic improvement. And we can say, using a so-called multinomial logistic regression analysis, that when the patient is really periodontally involved, then there is very likely that this kind of longevity of improvement cannot be achieved. When we are dealing with healthy individuals or patients with a stage 1 or 2 periodontitis, then we have 35 times less risk that this recurrent bleeding on probing will come back. This is when we treated the site, and as you can see, later with some further manipulation, a third implant could be inserted, and we have a stabilized corticalized bone level at the previously infected sites. To have the radiographic evaluation, we used the calibrated measurements of the implants. The implant length was given, and in that way we could do the measurements. If we could not find the apical part of the implant, then the diameter was used, and an Erasmus, nice German student, did the radiographic evaluation. I'd like to thank for it. We realized that 0.5 millimeter new bone formation was gained on average, and this is a typical case. It was not performed in my private office. These funny implants with a funny prosthetic work was placed, and when we tried to clean and high bleeding occurred, we realized that the abutment is moving. So therefore, we first removed the prosthetic work and then did the peri-solve treatment. 2 months later, you can see that the tissue is absolutely inflammatory free. Some 6 months later, we realized that at the mid-buccal part, where there is a lack of keratinized mucosa, the inflammatory process came back. We did the treatment once again, and after 6 months, how it healed, we waited further 1 year, and after a year, we realized that the tissue seems to be healthy, but due to the lack of keratinized tissue, we decided to do some further manipulation. For this subgroup, where we have mid-buccally lack of keratinized tissue, we evaluated how the healing went on at this side. We realized that mid-buccally 15 of 30 implants were improved. 1 was worsened, and at mid-buccally, when it was previously negative, no bleeding occurred, it still remained without bleeding, and we could regain 0.5 millimeter bone gain, which is quite compatible to the previous part of the peri-implantitis group. But if we think that we have lost only 1.7 millimeter bone or 2.4 millimeter bone, then this 0.5 millimeter could be enough that with the corticalization, an almost healthy crestal level could be, or remodeled, slightly reduced and remodeled corticalization could be achieved. If the keratinized tissue mid-buccally was still missing, then we decided to use semi-tunnelized flap. In 2 layers, we could tunnelize the flap, so we do not raise the flap as you do. We tunnelize the flap. That is the typical perio approach that you cannot see, but you enjoy it. So we did it, and as you can see, here is also at the neighboring tooth side a surgically treated periodontal defect, and also hyaluronic acid will be applied. The defect and the cleaned surface of the tooth using the clean and seal concept at the tooth side. then using some keratinized from the posterior zone gained tissue. I wanted to have it in a rotated manner, but the tissue was disrupted, and then we should suture it. But the tunnel buccally, as you can see, we did 2 tunnel buccally. This tunnel with some soft tissue further augmentation resulted in a funny structure, as you can see here. But it's quite obvious after the 1 month healing that we have more tissues, and without recession we could maintain the level of the soft tissue. And when we have a look at the newly formed mucogingival junction, it is inside the newly formed mucogingival junction, so at least the soft tissue is stable. And this is the bone answer or bone response to this technique, so we could achieve a corticalized bone configuration. Some few more cases. You can see that displaced implant. This is more or less one of the typical cases that you have early detected peri-implant mucositis, that the mid-buccal part of the implant is not completely anchored in bone, and also not completely anchored in attached mucosa. So therefore, if you have a soft tissue mobility, it is very likely that it will be inflamed. We went to this is the radiography. We immediately changed the bridge work for some abutments where only titanium will be located below the mucosa level. We did a tunnelized flap at the implant, and we did some open flap healing with connective tissue augmentation material at the neighboring tooth side. This is how it healed. Theoretically, it seems to be better. At least one corticalized part of the defect can be visualized. But after a year performing the vestibuloplasty, it's quite clear that this is not a healing, because there is a tendency that inside the defect it will be worsened. So then I decided to do a so-called minimal invasive surgical approach for the implant. I do not deflect the flap. I only pull the flap side apart from the titanium surface of the implant. I do the first from the CLEAN&SEAL concept, the Perisolve treatment. Then the dissolved tissue will be mechanically debrided, and after that you can see that even for the surface we can use some chitosan as a new approach for cleaning the titanium surface even more precisely without doing any harm for the titanium surface of the implant. And when it's getting clean, then this double tunnelized flap, the superficial mucosa layer and then the subperiosteal layer will be tunnelized and pulled apart. We place a lamina will be absolutely in the same way as you mentioned, will be softened by using hyaluronic acid on the surface of the lamina. That will serve as a buccal tenting function to give a certain support. For that case, I used allografts because I wanted to see whether it can really be applied and then later turned into a newly formed hard tissue configuration. Probably there are better solutions with hyaluronic acid and also some xenogenic soft tissue augmentation material. This is the very simple closure of the wound because it was not deflected, so it's very simple to get it closed. This is the early control. This is the 6 months control of the same side. You can see that the keratinized mucosa is still missing, but we have a deprived but existing mucogingival level and a non-mobilized mucosa at least, and this is how it heals. So I think an acceptable and quite vital bone configuration could be demonstrated on this, probably with some support of xenogenic particles if they can be implemented in the turnover of the bone, then it could be absolutely beneficial. So as an overall conclusion, I would emphasize that creating ideal soft tissue profiles around titanium and zirconia and trying to save a closed healing and probably an enlarged space for the healing with a coronally apically and linguobuccally displaced buccal flap side could be absolutely a good way of healing. And by stabilizing the wound, as Tony mentioned, that we have more space for wound stabilization, probably we can have an improved healing. One technique, which is without the tenting function and flap deflection, one implant was explanted. You can see the explanted side. Instead of raising the flap, this double tunnelized flap with the lamina buccal configuration was placed, and some soft tissue augmentation, and this is the inner healing of the flap. We waited a longer healing period of time, some 8 months, and after 8 months it was quite acceptable that all the threads of the neighboring implant was almost completely closed. Then we decided after 7 months to place an implant in. This is the healing, and this is the low abutment profile, where we can say that although the vertical part of the bone is slightly gone, but an acceptable result with a very simple surgical approach could be achieved. And some 2 more cases. One side we have some not correctly estimated condition of this. On the left upper radiography, you can see that the tooth is not vital, and there is a funny structure of like implant was broken in. And the long as I could not remove, or I wanted not to remove this broken part of the implant, there was some ongoing swelling on this last implant in the augmented bone. And it, after using the CLEAN&SEAL concept and when removing these very, very short root tooth and the remaining part of this mini-like implant, an ongoing healing could be demonstrated, and the final result is absolutely acceptable without using any grafting and without using any soft tissue augmentation. So inside there was enough space due to this vertical configuration to regain the bone. And also on the contralateral side, where I placed in the augmented bone a tissue level implant to avoid any later infection below the submucosal level, we could achieve a very nice and harmonious hard tissue healing with the same technique. So probably it's much, much simpler to use this closed healing if we have the chance to an early detected case, and if it's not a university case where the prosthetic part should not be removed, or you don't have always the chance that the prosthetic part could be removed, and we can screw the prosthetic elements out, then this closed healing and with minor soft tissue manipulation could help out that we have a closed healing for the implant and the implant can be stabilized. Finally, I think I can give a yes answer to you. Thanks a lot. Thanks for the kind attention.
So thank you, Peter. I think that was a clear yes. I would also say if I see your cases, and maybe I should start also tunneling not only in my recession cases, but in my GBR cases. Thank you for your presentation. With this, I would like to call the speakers on the stage. We have a small round table. I think we have some minutes left. Tony, Egle, please come to the stage. And we would like to discuss our lectures a little more. First of all, I would ask you, are there any questions from your side? Please. We have a microphone here. There's a question here from the auditor.
Sorry. Yeah, thank you very much. Sorry, I have one question about because you mentioned this phenomenon of the proliferation. So if I understand properly, during the wound healing, we have the native hyaluronic acid, which is triggering its signaling pathway, while the cross-linked hyaluronic acid is acting through a mechanotransduction pathway, right? So I was wondering if you evaluated if both pathways are active at the same time while you're applying the product? And if you measured if this proliferation is a controlled process.
So in the study that we presented with the cell culture study, we didn't measure that because, in fact, it was the first study that we did, and we wanted to see the effect. But it's a very good question, because for that, I think we need to have another setting. I mean, there are different methods. So I'm not an expert in cell biology, but for example, we could block, for example, the receptors for the endogenous hyaluronic acid, and then to see whether the effect is still there, or maybe to use some spatial labelings. It is not so easy to have a spatial labeling, and then there are some other methods, probably with some isotope stainings that you can again do. But I have to discuss it with our cell biologist which method could be used. But we discussed it, and she said that due to the effects that were in a magnitude that was not not confirmed in other studies that used endogenous produced hyaluronic acid. So these effects were probably attributable to the product used. Yeah, but I think the best way would be to block the receptors, and then you could do it. Yeah, but I think it's a very, very good question, because our body is producing it. But she said, I mean, we concluded that due to the magnitude of the effects, that was probably due to the product.
Thank you.
Okay, and the second question you asked is whether this proliferation is controlled. Yes, I mean it stopped at the end. The question is whether it is proliferates and proliferates, huh?
Yeah, because
Yeah. I mean, no, that stopped at a certain moment, huh? Yeah.
Thank you.
At least this is my current knowledge on that. So it was not, because we had the same questions also with other products like the Emdogain, that maybe this can produce an uncontrolled cell proliferation and could lead to, I don't know, tumor formation whatsoever, right? So, but that was not the case.
Any more questions from the audience, please?
Professor Windisch, I would like to ask you about your tunnel technique. Would you do the clean and seal before you open the tunnel technique and then continue with the tunnel technique?
First, I used it before, because I thought that could cause some harm to the tissues. Then I realized that during surgery it can be also used. So therefore, either you can use it before, or you use it before, and when you are ready with everything, you do it once again, because repeatedly 5-6 times you can use it. And then you see an absolutely clear surface of the implant of the neighboring side or at the tunnel, and then you decide whether you would like to close the surface of the titanium by soft tissue, or you can use some extraordinary wall, or due to the fact that you have double layer tunnel, you can pull out the tissues, and you decide what to do. The first choice is always soft tissue. I think it's very important not to go immediately for the reconstruction of the hard tissue, because the soft tissue proper coverage is still missing. So that is the problem with many peri-implantitis cases, that you don't have proper soft tissue to get it covered.
Okay. Would you use tie brushes as well, or do you only use hand instruments? Titanium brushes, or?
No, I don't use titanium brushes. Previously, I used GalvoSurge. Probably GalvoSurge could be also a part of it. Probably this very smart concept of using this chitosan involved brush is enough. But when I use this very smart brush, I realized that the titanium surface is very clean. So I'm absolutely convinced that not the infection coming from the titanium side is the problem if I have any kind of complication later.
Thank you.
Thanks.
There was one more question up there. Yeah.
Yeah, I think the question is related to Egle, but maybe it's also related to Regedent, maybe. So it's about the role of the amino acids in the formulation. So what is the exact role of it? Is it to give any sort of input to the cells? Is it to buffer the action of the sodium hypochlorite? And if so, have you ever tested with and without?
It actually buffers the effect of sodium hypochlorite to the soft tissues. It has a buffering effect, amortizes.
Okay.
Who could comment more?
So you mean the buffering effect, that it doesn't do any harm to the tissue?
Okay, any more question? Maybe I have one question. Peter, you
I
have a
wanted to
question.
ask a question.
Yeah, please.
When you presented the cases, the latest cases, you did not use any titanium tags and you use a different membrane. Is that right?
Yeah.
It was not the standard collagen membrane. It was, I think, a crosslink membrane.
Yes.
Can you explain why?
Yeah. I think there are two ways to go when you go for GBR. One way is either to immobilize your collagen membrane, which you have to do in a native collagen membrane, or you enlarge the standing time of the membrane, even going for a DPTFA membrane or anything. For me, the more demanding a defect is, the better results I see with cross-linked collagen membranes. So that's why I changed a little bit from tagging membranes, tagging native collagen membranes, going to more cross-linked collagen membranes, and even got more promised by that by using hyaluronic acid, because it seems to enlarge the standing time. So totally correct. The smaller the defect is, the more I go to a native collagen membrane. Maybe I also think of tagging it and stabilizing it. However, with this tenting technique, pole technique, we see in a lot of cases a stabilization with pins and tags is not really necessary. The more demanding a defect gets, I mean, remember that these native collagen membranes, they come from periodontal surgery. They come from periodontal regeneration. So if you have a free end regeneration, I think the standing time is not enough. So then I go for cross-linking, and I'm happy that we have a tool with hyaluronic acid.
I got similar answers from Anton for peri-implantitis.
Any more question? I have maybe one question to Tony, which wraps it up a little bit. Tony, one question which always comes to our mind and which we hear always is, how do we compare that to PRF? I mean, this is what we hear a lot of times. I mean, could I use PRF instead? I mean, you could lecture for an hour, but just in a nutshell, I mean, where's the pivotal difference to PRF when we're seeing our results of hyaluronic acid?
It's a very good question. It's difficult to answer it based on a study, because if you would like me to answer it, we should do a comparative study. But if you would look at let's say in a cell culture, okay, you would compare PRF, which is already a growth factor, PDGF, with hyaluronic acid, then the effect of PRF is stronger, no doubt about it. However, when you use it in the clinic, then you have the cells, and the cells are in fact in the blood clot, or the blood clot will attract the cells, and they will produce the growth factor. So in a biological setting, in a wound, hyaluronic acid would modulate the innate release, autogenous release of growth factors. So for that purpose, I think we may have comparable results. Maybe it's even more stable. You could use it as a carrier. But of course, if you have different preparations of PRF, you have IPRF, you have, I don't know, more stable PRF than heated PRF. There's a whole story about that. If you have a practice where you use PRF routinely, then of course you don't need maybe hyaluronic acid, honestly, because you have it. But most of us are dentists, and most of the dentists do not know how to draw blood in their daily practices. So most of the dentists prefer to take something from a shelf and to use it as simple as possible. This is what I would do in my practice, because then I don't need somebody who is drawing the blood whatsoever. So is easier than in certain countries. You have the transfusion issues. You cannot play with the blood as you want. Depends on the country. So I think that if you have a lot of routine using PRF, you may not need hyaluronic acid, but the majority of the dentists would prefer to have it, including myself, from a shelf. Yeah. We have also the practical aspects. So I have seen last week a presentation in Berlin. This may open new horizons where one maxillofacial surgeon used both. So in fact, combined hyaluronic acid with PRF in order to stabilize also the bone graft
and put pressure
and to put pressure on the whole system. So it can be also a carrier. So I think this could be also something that opens ways for the future. But I think that another way we started to work is to go into the direction of exosomes and instead of PRF. And then we use exosomes. They are already clinically available in the United States. We are working on some projects now in Bern. And in fact, using hyaluronic acid as a carrier for in combination with exosomes. I think we have different, different waves of using it and different indications, and is an open field for research and clinical applications. So I cannot answer it to you black and white.
Got it.
So
I think that was a good conclusion. Also with a blink into the future. With this, I would like to thank our speakers. I think it was a round table, round flowers of application of hyaluronic acid, of different indication. Thanks for that. Thanks also for mixing clinical aspects with scientific aspects. With this, dear colleagues, I would also like to thank the company of Regedent. I think there are possibilities to look at that video or to that session also down the road. With this, I would like to thank you for your attendance. I wish you a very nice evening here in Monaco and a great rest of the Congress, and enjoy Monaco. Good night. Bye-bye.